right, I think that's everybody that's in the waiting room. So welcome everybody. My name's Ivy Bergeau. I'm very pleased to be a co-lead on Team Primary Care Training for Transformation. I'm particularly pleased to welcome everybody here for this really critically important discussion that we're going to be having. So this is the second of our Team Primary Care webinars, and I also just want to start off by acknowledging territory. I'm coming to you from the unceded, unsurrendered territory of the Algonquin Anishinaabe people who are here in the territory we know as Ottawa. We are coming to you from coast to coast to coast, so if you could take some time to reflect and pay respect to the territory that you are coming from, please feel free to do that in the chat. We pay respect to all Indigenous people from coast to coast to coast. We acknowledge the traditional knowledge keepers, both young and old, and honor their courageous leaders, past, present, and future, and are very pleased to have providing us guidance on Team Primary Care, our Indigenous Advisory Committee, and I'm going to pass to Marilee to take it from here. Thank you.
Thank you, Ivy, and thank you, everyone. Thank you for coming to today's session. And before we begin, I want to start us off in a good way, and by doing a little prayer before we engage in our session. I want to thank the ancestors and thank the Creator for the day that you have given us today. I am coming to you from this, our Treaty 6 territory, where I'm in their territory as a visitor today before I head home to my family on the unceded territory of the Algonquin Anishinaabe. I want to thank all of you for your time, your diligence, and your attention to these webinars. I want to acknowledge our ancestors and the people who brought us here today to be part of this journey. And I welcome the ancestors of our non-Indigenous ally partners and our networks, whom ancestors have brought you here to be part of this journey. I want to ensure that each of you are aware that you are protected in this safe space during this time. Chimigwech. Thank you for that. I am Marilee Nowgesic. I am the Chief Executive Officer with the Canadian Indigenous Nurses Association. Before we begin the session, and I will allow each of the panelists to introduce themselves, I will just mention them by name, but I would like to make sure that all the attendees are aware that this is a very heavy topic in regards to content, subject matter. I sound like one of those TV commercials. There's no coarse language of violence, so we're good there. But I do want to urge you to look after yourselves. Some of the things can be triggering and can be sensitive. Please look after yourself in whatever way it is that you do that. If you need some help post this event, please contact one of us. I'm sure we'll be able to guide you in the proper direction. Having said that, welcome to our the Team Primary Care Indigenous Advisory Circle. What we are doing is we're trying to do the liaison, the network, and the development of what Indigenous advisory will mean to the Team Primary Care process. And having said that, there are a lot of things that need to and can be done and will be done with your cooperation over the next several months. One of the things that has come forward and has become a focal point is the Truth and Reconciliation Commission's calls to action. By doing so, what we are allowing for in that process is to open up the gateways for discussion and dialogue between Indigenous partners and non-Indigenous partners and networks. What we are hoping, the Indigenous Advisory Circle Committee, is that we have nothing to reconcile. What we want to do is work with our non-Indigenous partners whom are working on those calls to action. We want to be there to help guide you in that process to understanding the protocols that are necessary to our First Nations, Inuit, and Métis people across the country. It can't be just one thing for everyone and hope that it works. It won't. But with that, I have my colleagues as part of this circle and part of the presentation today, whom will describe for you the next portions of the the agenda. Can I have the next slide, please? The agenda is self-explanatory. So we have several items. We'll be looking at the Indigenous Advisory Council. So I've already done that with you. Mandy, Mack will talk about the IPHCC. We'll get the cultural competency typo done there for everyone. We noticed it, so versions, work with me here. So here's a little bit of the agenda and what we want to be able to do with you. As with the other committees as part of Team Primary Care, we are working with each of them in what we can help with there. So that it's not just a silo effort, you're working alone. That's not what this is about. Next slide, please. So having said that, we got together back in Ottawa to looking at what each of the Team Primary Care committees would be doing. The conveners of the Team Primary Care overarching process contacted each of our Indigenous organizations. In doing so, we all have similar strengths, skills, perspectives, and knowledge that needs to be translated to each of the committees that compose Team Primary Care. What we are doing here is we're looking for gateways and paths to be able to develop that dialogue towards meaningful engagement of not only the Indigenous Advisory Committee, but also the allied partners and how we're going to work with you. It's not doing stuff for us. We can do that. We want to invite you into that engagement, into that process, and we want to be at your tables to providing you with advice, suggestions, recommendations on some of the nuances, some of the protocols, and some of the traditional ways of knowing that you need to be aware of. Not all of the ceremonial or traditional ways will be part of your wheelhouse, shall I say. You will not be allowed in some of those segments for various reasons. We will explain that to you when it does happen. But just so that you know, we are trying to keep this open, transparent, and cooperative manner. With that, I'd like to now introduce your first panelist, and I will allow her to just do an introduction of herself. It's with great honor that I introduce to you Mandy Mack. Mandy?
Shimigwech, Marilee, for that wonderful opening and starting us off in a really good way. Wachie, good afternoon. Chimigwech, everyone, for coming out this afternoon. I apologize if there's some background noise, but that does happen when we work from home. So I'm originally from Attawapiskat First Nation, which is Cree territory. I sit here on behalf of the Indigenous Primary Healthcare Council, which is primarily based out of Ontario. And yeah, just really happy to be here and to share some important dialogue about what ReconciliACTION looks like for Indigenous peoples and our allies that we work with across the board. So I'm not sure if we're sharing the opening introductions or we're just getting right into it. Marilee?
Sorry, I turned my microphone off. If we could just get right into it, I think we need to maximize the time and we can go right in. Right. Thanks a lot, Mandy.
Okay, no problem. So next slide. So just to talk about the Indigenous Primary Healthcare Council. So just a little bit about us. The Indigenous Primary Healthcare Council is a provincial nonprofit organization. We recently incorporated in November 2019, although we've been operating informally for many years to serve the primary healthcare needs for the Indigenous community. The sector, though, itself, so AHACs, Aboriginal Health Access Centers, has been around for over 30 years and has continued to expand and grow in different capacities. The IPHCC has established provincially to serve over 6,000 documented within our sector since 2016. The IPHCC is made up of members and associates from 28 Indigenous community healthcare organizations, including Aboriginal Health Access Centers, Indigenous Interprofessional Primary Care Teams, Indigenous Community Healthcare Centers, and Indigenous Governed Family Health Teams. Next slide, please. So Just a little bit more about who we are, our vision. We envision a world where the health and well-being of all Indigenous people in Ontario is restored and assured. Health systems provide Indigenous people with high-quality care, empathy, dignity, and respect. Our mission, we use Indigenous solutions to transform Indigenous health outcomes and decolonize health systems by empowering the voices of Indigenous peoples and communities to affect change, partnering with Indigenous communities, mainstream health organizations, and government agencies, gathering and sharing data about health status of Indigenous peoples in Ontario and inequitable service gaps, equipping council members with the tools and training networks to provide quality health care. So that's just a bit about us, but our role within Team Primary Care is to help embed traditional understandings, ways of being and knowing within Team Primary Care. So right now we're working on an accreditation model for traditional healing and cultural practitioners and ceremonial practitioners. We're working on a mentorship training program to support the sustainability of our traditional healers. Many of our healers are passing on, so we're working on a model that could help sustain the healing practices that we have within our own communities. At any time, if anybody has any questions about our project, we do have some information that's already been shared with Team Primary Care. I am the lead contact for the project, so if anybody wants to reach out to me individually, please do so, and I'm happy to engage.
Thanks a lot, Mandy. Just to let everybody also know that there is a chat box if you have some questions, and please also provide us with a little bit of your land acknowledgement. Where are you coming from? Where are you joining us? And what we like to add to sometimes is, as part of a little learning engagement, what's the treaty area or what's the area of the Indigenous people in your geographic space. Next, I'd like to introduce Ruben to do the next segment of the presentations. Thanks, Amber.
Absolutely. So you may have heard the term cultural competency, and that's a term that's commonly conflated with cultural safety. Cultural competency is an approach that focuses on acquiring skills, knowledge, and attitudes to work in more effective and respectful ways with Indigenous people and communities. However, being knowledgeable about a culture alone does not go far enough to address the underlying health equity issues that permeate the systems we live in. This is why the IPHCC accounts for cultural competency education within a broader cultural safety approach. There's a spectrum upon which cultural safety is situated, and it includes cultural awareness, sensitivity, competency, and then safety. The other pieces of this dynamic spectrum include cultural awareness, which is having an understanding that there are differences between cultures, cultural sensitivity, whereas there is the realization that our own cultural views influence our viewpoints and biases, and cultural humility, which is the recognition that learning to apply culturally safe and appropriate care is lifelong. Cultural safety, which the IPHCC and all healthcare professionals should strive for, is an outcome based on respectful engagement that acknowledges power imbalances inherent in the healthcare system. Cultural safety considers how social and historical contexts, as well as structural and interpersonal power imbalances, shape a person's health and healthcare experiences. That's a lot to unpack in a single definition and sentence. So I think I want you to think about that a bit more. And so it is not just historical context, it's current social contexts as well. It's not just power imbalances within our healthcare organization as a whole, but it's also power imbalances between healthcare professionals and patients. And that all of these factors play a role in patients' health and their perception of their healthcare experiences. So healthcare providers and organizations that practice cultural safety are self-reflective, self-aware about their position of power and the impact this role has on Indigenous patients. You may work with one group or person and be able to provide care, cultural safe care in one way, but that's not necessarily transferable to another patient or group. In the context of providing care, one patient may call for an approach of care that might be easier for you to accommodate as a provider, and others require care that is harder for you to provide. But it all is just to say there's no single way to provide culturally safe care, and it's important to work with your patient. Cultural safety is defined by those who receive the care, not by those who provide it. It's a framework that integrates awareness, sensitivity, competency, and humility. It's a paradigm shift in the way we practice. And I'll pass it off to Nathalie.
Hello, everybody. My name is Nathalie Pambrun. I'm a Franco-Manitoban Métis midwife. I'm calling you today I'm originally from Treaty 1, but I'm calling you from Lekwungen territory, calling you from the West Neck, Songhees, and Esquimalt people's territory, where I'm a guest. So I will take it away here, looking at this cycle of cultural safety. Essentially, it is a dynamic, sort of ever-changing process, and where we begin is at that any point in care when we're able to combine all the phases that kind of make up cultural safety. So part of that is acknowledging our colonial history through that ongoing reflexivity and recognition of the barriers that can arise and the power dynamics that exist between providers and patients. I really like to bring up anti-racism at this point. Like cultural safety, it's both a process and an outcome that, as Amber mentioned, is determined by the person receiving care. So anti-racism requires sort of that continual self-reflective effort at all levels, whether it's you as a provider in the care that you're providing every day, maybe at the organizational level, looking at the layers in which and how care is organized, that requires transformation and change, so that folks who are Indigenous, either the ones that you're working alongside or the people receiving care, feel respected and welcomed. So the systems in which we work and serve can't limit our learning to just, an onboarding activity when someone first starts within your organization. This is something that hopefully we're going to be pushing at the levels of our regulatory bodies to be seeing, cultural safety and anti-racism as a prerequisite, just like your ongoing core competencies. And so it's cultural safety really stresses that importance of refreshing our learning and staying up to date with the various strategies that allow us to provide safe care. And it's not really a linear process. It's affected by the ecosystems in which we work. And so it's important to revisit all aspects of whether it's self-awareness, the competencies and skills that we can teach to our practitioners, and that humility that's required along the way. And so I think it's important to recognize that Indigenous people are often subject to multiple intersecting forms of racism, discrimination, and stigma. And that can be gender-based discrimination and stigma, can be related to substance use, and substance use health, regardless of whether or not they use substances. And so anti-racism and anti-stigma strategies are really intertwined and essential to close the health equity gap. So I think anti-racism is an important health equity practice, and it involves changing our practices, our policies, our structures to actively counter racism. Pass it back to Amber and have the change slide.
Thanks. I should have given a quick introduction of myself. Sorry. I'm Amber Ruben. I'm a Nowgesic. I'm a hospital pharmacist practicing for about 17 years on Treaty 6 territory. I was born and raised in the Northwest Territories in Treaty 8 territory. And as well as being a current pharmacist, I am also a master's student. that's an aside, I'll get back to it. So why is there a need for cultural safety, especially with Indigenous peoples within our healthcare systems? They systematically experience more chronic diseases, infectious diseases, mental illness, and addiction because of the way intergenerational and historical trauma has shaped past and present lived experiences. So we can take steps to reconcile in healthcare by enabling Indigenous peoples to define their form of cultural safety. This way, we are better positioned to achieve health equity as perceived by Indigenous communities. Mandy? You're just on mute, Mandy.
Sorry about that, folks. Thanks for your patience. So what we were hoping to just talk a bit about was the historical overview on why cultural safety is so important. Some of the experiences that our First Nation, Métis, Inuit people had to go through since colonization. So what is unique about the Canadian Colonial Project is how often it speaks to, or in a benevolent voice, while its action speaks to its role in undermining Indigenous nationhood and rights. The relationship between settlers and First Peoples of this land has always been fraught. The contact period began as early as the 1400s and lasted at least a century. This refers to the time period in which settlers first landed upon what we now refer to as Canada. And this period brought death through epidemics, starvation, and warfare from foreign invests vying for natural resources. While there may have been times of allyship between settlers and Indigenous people, these are often transactional in nature. So from the 1600s to the 1750s, there was an epidemic period. The epidemic period followed the contact period for almost 150 years. This era ultimately led to the deaths of millions of Indigenous peoples from very southern tip of North America continent to the northern territories of Canada. Interestingly, we have scapegoated Indigenous populations for their high rates of TB, but it is ultimately the settler population that brought death and disease to the First Peoples of this land. We can also conflate alcoholism to First Nations populations, but alcohol was first introduced through settler contact. From the 1800s up until the end of the 20th century, we entered what can be referred to as the Indian educational period. While this period originally began through missionization and a targeted attempt on a part of a Christian missionary to convert Indigenous populations to Christianity, this era eventually developed into the proliferation of day schools and Indian residential schools for almost 150 years. Arguably, the impact of residential schools lingers today for several communities in Northern Ontario as they continue to remain underfunded and undersourced, leaving Indigenous children to travel great distance away from their homes, communities to access just basic education, particularly elementary education. So then in the 1800s to 1981, began the Indian hospitalization period. So the Indian hospital period ran parallel to the Indian education period, and it saw the government opening more than 22 hospitals, surpassing 22,100 beds, most of which were located in Ontario and Western Canada. These hospitals originally opened to isolate TB amongst Indigenous populations, but ultimately functioned as a racially segregated hospital where Indigenous patients were provided substandard care. As we move down the road, starting from 1960 to today, we've entered into the child welfare period, and some people may know it as the Millennium Sweep. So the child welfare period, which includes the 60 scoop and current day millennial scoop, represents the way in which the child welfare system operates as a tool to further assimilate and displace Indigenous children from their families. This systematic removal of children continues today, with as many as 52 of Indigenous children being raised outside their families, cultures, and their nations. So as you can see at the bottom of the slide, we have an arrow indicating the inception and continuation of the Indian Act. The legislation outlines in this act continues to have an impact on First Nations communities in the areas under which it has oversight, including land status, reserves, education, and treaty rights. As mentioned earlier, it has also complicated the rights and freedoms that could otherwise be exercised freely by Inuit and Métis individuals. So within our second arrow here, as indicated by the second arrow, we show this that since first contact, Indigenous women, girls, and gender diverse peoples have been affected by violence and misogyny. In 2015, the National Inquiry into the Missing and Murdered Indigenous Women, Girls, and Gender Diverse People concluded a direct link between colonization and the violence experience. The Native Women's Association of Canada has seen higher cases of murder than the national average, and even today, a number of individuals remain missing. Next slide, please. So then we also have the history of experimentations. So the history of experimentations continue to be a reason of mistrust in the healthcare system. So as you know, or may have heard of, nutrition experiments were often done on First Nation peoples, performed by the Department of Indian Affairs on over 1,000 children in 6 residential schools across the country from 1942 to 1952. Parents were not informed, nor was consent obtained. In these experiments, control and treatment groups of malnourished children were denied adequate food or any type of nutrition. The intent was to test experimental fortified flour mixture on residential school students, which at one time there was a federal ban on the flour. The researchers found increased incidence of anemia among the children who were fed this experimental flour, contributing to more deaths and certainly impacting development. Even as children were dying, the experiments continued with efforts made to control as many factors as possible. Even when they harmed the research subjects, for example, previously available dental care was denied in some settings because the researchers wanted to observe the state of dental carriers and gingivitis with malnutrition. Forced sterilization. Sexual sterilization. The Sexual Sterilization Act was passed in Alberta in 1928 and in British Columbia in 1933. Federal government used it as a form of birth control in First Nations communities. A documented 580 sterilizations took place at 2 federal hospitals within Ontario. Consent was only received in 17% of the cases. The last reported case of forced sterilization among Indigenous women occurred in 2017. Next slide, please. So having given all that historical context where we are, like where are Indigenous people today? Well, as you may have known or heard, homelessness, substance use, elevated suicide rates, they're all symptoms of the ongoing suffering experiences by Indigenous people through colonial institutions and policies such as residential schools in the 60 Scoop. Current medical mistrust is also a result of the racism experienced when Indigenous people access services. Many First Nations, Inuit, Métis people have reported being ignored, belittled, mocked, disrespected, and discriminated against by a healthcare practitioner in the mainstream Canadian healthcare system. The attitudes and behaviors are causing harms that include delay and or denial of treatment, resulting in substandard care, negligence, worsened health conditions, or even death. Next slide, please. So we just wanted to take a minute to just reflect on some of the information that we just heard. I know it's a lot of information that we kind of just had to take care of in this short time that we've shared together. But we welcome you to utilize the chat here to maybe express yourself or just take a deep breath and, whatever you need to do to ground yourself again if you found that you've experienced some uncomfortable feelings while hearing this presentation so far.
Next slide, please. So these are the most common stereotypes. They came from the In Plain Sight report and were collected from healthcare professionals in British Columbia. The truth is that as Indigenous people, we're as worthy as anyone else. Indigenous patients are coming into care carrying a historical background and story that has not been corrected by contemporary education. Many Indigenous people are non-drinkers. A significant number of people don't drink alcohol at all. Yet the Canadian population at large consumes almost 23 billion per annum. A recently released report found that Canadians aged 15 and older drank 10 liters of pure alcohol per capita in 2016, 3.6 more than the world average. Drug dependence. Some Indigenous patients are drug dependent, and there are problems to be solved, but assuming that we are all drug seeking may mean a life or death situation for a patient who is genuinely ill and needs medical attention. We are good parents. At least 16% of intergenerational survivors of the Indigenous residential schools 60s scoop and other child welfare impacts are wonderful parents and are raising well-adjusted children. Frequent flyers. Access to culturally supportive healthcare system is challenging, and family doctors are unavailable in many regions, especially in the north. That we are irresponsible and less capable. There's deeply held biases and beliefs about Indigenous people and people of color. The truth is, there's also deeply held fear of hospitals and healthcare professionals from a historic and contemporary experience, and people wait too long for primary and intensive care. Advantaged. There's really limited advantages for Indigenous people in the healthcare system. I'm going to pop a resource into the chat here that I think everyone should look at. And it is a great resource to respond to discrimination. Change slide, please.
Okay, miigwech. Some of the experiences that we want to talk about is from people that you may have heard their stories. You may have heard Michelle Lebrec's story. So Michelle is an Indigenous woman who sought medical attention for what she described as severe stomach pain. She discussed the pain with a doctor, as well as her struggle with alcohol and finding a home. The doctor wrote her a prescription and told her she was good to go. When she got home, she discovered that the doctor had given her this. So what do you think of the doctor's note? What thoughts come to mind? Many Canadians feel that Indigenous populations are a burden to the healthcare system. Please feel free to use the chat to share your thoughts on that one. And then some of us may have heard the story of Joyce Eshquan. I'm sure everyone has heard of Joyce Eshquan. Joyce lived midstream. She was Joyce was receiving healthcare, and then during her time at the hospital, she was taunted moments before she died in hospital in Quebec. Joyce was 37 years old, a mother of 7, and she went to the hospital because of stomach pain. While in her bed, she complained that she was being over-medicated. Her death has sparked conversations about systematic racism in the healthcare system. Quebec's coroner launched an investigation into her death, which has so far heard from patients who said Joyce was mistreated in the hours before the video was posted. Staff who said the nursing student who treated her was not provided adequate support, and an expert witness who said her death could have been prevented. So that's just some of the experience that we're hearing across the board, but there are many experiences that we are learning about through our sites or membership that we work for who access care within mainstream healthcare settings.
So stigma is still a large problem within healthcare systems, and it begins with the labeling of differences between and negative stereotyping between people, creating a separation of us and them. And I was just reminded of this even at bedtime last night when I was putting my littlest to bed, and they had played a First Nation version of the Canadian anthem with some drumming. And he said, "Mom, I was so sad at school today, and it hurt my heart. Some boys were laughing at the drumming and making fun of it." And this is exactly the type of labeling and differences that are pervasive throughout our Canadian systems and not just in our healthcare systems. But those who are stigmatized are devalued and subjected to discrimination and unjust treatment. This can lead to disadvantage and inequitable social and health outcomes. Stigma happens at multiple levels, at an organizational level, at a population level, through interpersonal relationships, and internally, people's self-worth and value are affected. This in turn affects healthcare because when people feel stigmatized, they may feel isolated, unworthy of services, and unwelcome, and therefore unsafe and uncomfortable about going to health centers or hospitals to access services. And I'm finding this just in my conversations with people who are participating in my study as well. Those who have experienced stigma with the healthcare system do not want to approach our system again. And this leads to people who are presenting very unwell. To combat stigma, we need to consider each individual as a whole person and not just focus on the behavior we don't like or don't agree with. We know there are people in our lives who struggle with things like substance use because of many complex reasons, including trauma, grief, loss, and pain. We also know that there are many things that bring us each joy, love, and purpose. And so it's important to focus on these aspects of our lives. People who cope with intergenerational trauma in ways we perceive as risky behavior are valuable members of our community. We label them and stigmatize them, and then they become less than human, so it's easier to cast them aside. But what we really need to recognize is that these people are our community members, our family members, and our friends. So we need to find ways we can support each other to reduce stigma. Some of the ways we can do that is to use people first language. So instead of saying users, addicts, alcoholics, we can say people who use substances, people experiencing an addiction. And it's important to share accurate information. Be mindful of the information we share. Working in the hospital, I know how easy it is for a new diagnosis to land on a chart. Let's say somebody has had a binge drinking episode for a few days. All of a sudden they are labeled as an alcoholic or somebody who has an alcohol use disorder. And that carries through and it continues and stays with them. So be very careful about how you use these labels.
Being aware of the history and its impacts on Indigenous people means that we need to practice in a trauma-informed way. Recognizing that the healthcare system and those of us working within it are not always trusted. So we have to be patient. Things that we can do as an individual, a provider, or an organization is not just to sympathize. As Mandy's title indicated, it's time to take action against discrimination and racism throughout the system. We need to use our power to decolonize our own self, our families, our communities, and that means decentering Western ways of doing as the only right way of delivering healthcare. Next slide, please. Trauma-informed care. In order to best support Indigenous people in health systems, it's important to know the journey they've been through. It's important to remember that colonialism is defined as control by one power over a dependent area or people. It occurs when one nation subjugates another, conquering its population and exploiting it, often while forcing its own language and cultural values upon its people. Racism and colonization are intertwined, and together they deeply impact the health of Indigenous people in Canada. Systemic trauma and racism underlines every aspect of an Indigenous person's life, and if we want to see different outcomes, we have to be willing to do our work differently. The goal of trauma-informed care is to support people to make decisions about their healthcare and treatments needs in ways that feel safe to them, while avoiding the possibility of re-traumatization. When people are in a trauma-like state, it's hard for them to come into their frontal cortex. And so part of it is when someone is coming into your office, you need to be able to make them feel safe and comfortable before launching into information sharing and asking questions. And so I think it's important to develop those compassionate, informed services and culturally safe ways to improve access to services and the way in which we deliver services. Because hospitals and health clinics can feel unsafe for someone who has experienced trauma, we need to create that safe environment. And it begins with that awareness amongst our professionals, our staff, and being able to develop an approach that feels welcoming for everyone who's coming in. So when healthcare professionals build their awareness about the factors and experiences associated with trauma, we're able to change our organizational culture and create a compassionate and informed approach towards all people receiving care. And a compassion-informed approach to healthcare really emphasizes the person's safety, choice, and control over their own care, and being able to create their own view of what is their risk tolerance and safety. So I'm going to put another great resource from Equip Pathways into our chat here for people to look into, and I'll pass it to Amber.
I think one of the concepts that had the biggest impact on me when I was learning and thinking about trauma-informed care is the idea that when somebody has a trauma, the behaviors we see are their response to the trauma. They are not making bad choices. They are not bad people. They are just coping with their trauma. And that had a large impact on me, even as I was thinking about family members whose behaviors were not what I expected based on how they had grown up in childhood. And so I couldn't understand why people that I knew had alcohol use disorders when they had hated seeing that in their own family members. And it helped a lot to recognize that this was their coping strategy. This was the mechanism to deal with that trauma. And I think if you think about it that way, it is easier to prevent that stigma and to understand why that behavior might be happening. So Equip Pathways have created resources focusing on trauma-informed care, and they provide 4 principles of care. So the first principle is to understand trauma, violence, and its impact on people's lives and behavior. So they also have created organizational strategies and provider practices that are listed here so that you can use those both within your organization or within your own practice. And so I'll also share some resources in the chat once we go through these principles. The second principle is to create emotionally and physically safe environments for all clients and providers. Feeling physically, socially, and emotionally unsafe can cause extreme anxiety in a person who's had a trauma response, and that can potentially cause re-traumatization. So it's important to create a safe environment that's fundamental to successfully engaging patients in their care. So just take a moment and think about the following. Does the entrance feel welcoming where you work? Does it foster an inviting environment for Indigenous patients? And what are some of the steps taken at your organization or site to create these safe spaces? share some examples in the chat. The third principle is to foster opportunities for choice, collaboration, and connection. A lot of people who have trauma don't feel empowered at all. They don't feel like they have any power. So allowing decision-making and collaboration is truly very important to help people with empowering themselves. And use a strength-based and capacity-building approach to support clients. So one of the biggest barriers I think we have in healthcare is that we don't have a lot of time. And so not having enough time doesn't allow for meaningful engagement with your patients and to allow this sort of approach to happen. And so I think one of the things that we all need to think about is how can we allow that time to build that engagement, provide those options, and have meaningful discussions where people are collaborating in and part of their own healthcare decisions. This goes back to the idea that we can't be patriarchal any longer in our system. And I think we are definitely trying to move away from that. But sometimes time doesn't allow people to be involved in that collaboration. And again, we have to focus on people's strengths. So if you can think of an example where you've used a strength-based or capacity-building approach within your own practice.
Miigwech Chamber. So now that we've had a better understanding of bias, stigma, and trauma-informed care, how do we put this into practice and use this knowledge to inform our relationships with individuals and communities? We recognize that people are eager and curious about what the next steps they should take to start building these relationships. I did want to acknowledge that all these are very, very heavy topics. It can be complex, but I know that with this knowledge that you just learned, that we can learn to inform ourselves and inform the kind of practice we want to provide for all Canadians. So just one of the things that we were hoping to cover today was how do we build and restore trust and confidence with Indigenous peoples? And the first thing is probably taking up training to teach yourself about the history between Indigenous peoples and settlers, and to learn skills on how to best engage with Indigenous peoples. And then how we can do that is not actually just attending trainings, because training, having an understanding is just one part, but the other part could be participating in community events, or many urban areas have a local friendship center that is welcome for everyone to come. Indigenous peoples at friendship centers welcome anybody to come in and learn about the culture. So, maybe volunteering at one of these friendship centers, if you haven't engaged with the community within an urban setting, that may be something that you could start with. And then help with reviewing the policies that govern your department and your organization. Make changes where relationships can be fostered and strengthened. So again, having a strength-based approach, what can we do to, there was a lot of questions when I attended the Ottawa gathering about where's the calls to actions within team primary care? What are we going to do? What are the next steps that should be taking to implement these calls to action with respect to Indigenous peoples? So these are just some of the examples that we could work with moving forward. And then share your learnings with colleagues and friends, and ensure you speak up when others make inappropriate jokes or comments about Indigenous populations. So thank you. Next slide, please. So I wanted to take a minute to, again, just take a little bit of a break, not to go anywhere, but just, take a minute to take a deep breath in, or for myself, I always get nervous with these types of speaking engagements that have to do with reconciliation and, discussing the history of our Indigenous people. The reason why that is because, I was raised with all of these colonial constructs. I was raised in the foster care system. I was raised as a mother who and parents that attended residential school, and and how that has affected my family, and having real lived experience on what kind of trauma that's been inflicted on my people. So sometimes it can be a little bit triggering to share this information constantly, but we do this with the hope and understanding that this information is going to be used in a good way to inform your own actions on how you want to engage with Indigenous folks moving forward in a good way. So, I'll hand it back to Nathalie.
Thanks, Mandy. So I think what we'd like to see is in each of your projects that at the forefront, you are prioritizing a truth and reconciliation call to action. Maybe it's to increase the number of Indigenous professionals working within your healthcare field. Maybe it's to ensure their retention and ensure the retention of Indigenous healthcare professionals working in Indigenous communities. Maybe it's to provide cultural competency training for people within your field. But as we've indicated throughout this presentation, this work is all of our work, and to see it being prioritized, being Indigenous led, and having folks build those relationships. So if you can go to the next slide, a big part of reconciliation is moving us into that action space. And so what we want to see is that you start to build those relationships, engage with maybe you have Indigenous health providers as part of your organization, engage with elders, healers, cultural practitioners, and meaningfully involve them in your project. Whether it's in the co-creation of the delivery of community-based services that might be happening, or the education pieces. And it's important to share the funding resources that you have with those folks. And that's part of a necessary component of equity and us working together to transform our system. I think fostering an overall respect for Indigenous health knowledge and the way in which we see wellness and health is going to transform primary healthcare delivery in a positive way for everybody. Next slide, please. Mandy, I think.
I'm sorry, I had to turn off my mic because my dog was barking in the background. So sorry.
Okay, you were very contemplative, so I was like, oh, there's something going on there.
So thanks, everyone. We're going to just move really quick now because I noticed that we're kind of time sensitive now. But one of our core functions at IPHCC is using a two-eyed seeing approach. And a Mi'kmaq elder, Albert Marshall, shared this teaching about as Indigenous peoples and living with, our non-Indigenous folks. There's two sets of knowledge and two sets of being and two sets of thinking. And so, and how do we work with that? How do we use a two-eyed seeing approach? Meaning, how can we work with both knowledge bases for a better world? And so, that what essentially is two-eyed seeing. And so for also Indigenous people is that we live in this Western framework and world, and we walk in two worlds in a sense. We have our Indigenous ancestral knowledge, and then we have to go to school to learn Western knowledge in order to practice a lot of our medical care, healthcare, that kind of stuff, to be practitioners in that. So so we can send you more information about the teachings of Elder Marshall, but we also have some videos that we could put in the link. Yeah, but there's somebody at my door, so I'm gonna have to sign off on this, but you could take over, please. You go.
Sure, no problem. You can go to the next slide. I'm gonna pop in the chat a few really excellent examples of two-eyed seeing in the ways in which we're seeing it being used in various circumstances. I would say as an Indigenous midwife, or just, and probably as in many cases, Indigenous health providers within your sector have naturally sort of taken this approach to the work that they do. And certainly I would say that one of the ways in which we've adopted this particularly is that we recently created the core competencies of an Indigenous midwife that sort of illustrate the ways in which we see and care for our clients differently. And so that's, I'll send a link in there as well that kind of shares some of those perspectives. And go to our last slide, please. So all in all, I know that this has been a very loaded and full webinar for everybody. And I think a next step is really good to reflect on what information struck you the most, and what would you maybe like to learn more about and why, and what could be your next steps within your own project that will allow you to create constructive actions forward, so that we don't have situations like the Brian Sinclairs and the Joyce Echaquans within our healthcare system, and that we're bettering healthcare as a place of like health and wellness for everyone. I don't know that we have a lot of time for questions, but I'll just maybe let Marilee have a last reflection and thought.
Thanks a lot, Natalie. So first of all, I want to congratulate my colleagues. That is probably the most stuffed in hour of Indigenous health and history across the Canada. Congratulations to my colleagues. That was well done. To the attendees of the session, as you can see, there is a lot of room for discussion, growth, dialogue, and for the engagement between the Indigenous advisory circles and our allied partners and our non-Indigenous partners. We are looking forward. As you can see, this is just a small wedge of what the expertise is that we have available as a part of this advisory. Many of you will have looked at what this conversation is going to move forward. This is not the end. This is opening the doors, the windows, the TP time, our tea time, not golf, actual tea. So let's look at how we're going to look at the next steps together. Please leave some more questions. Look at the resources that have been posted for you. I'm so looking forward to the next steps with you. As we look to closing this session, I need to call in the ancestors again whom have protected us during this safe space and during this journey in time, and to thank them, and to thank your ancestors that you have brought forward to this journey also. And thank you for protecting us in this very safe space and allowing us to be part of the discussion with you and with us. Chimiwech, have a great day wherever you are. Be kind to yourself. Until we meet again.
Thank you so much, Marilee, Amber, Nathalie, and Mandy. On behalf of Team Primary Care, such important information, and I didn't want people to let this kind of percolate and sit with them. We are open to any comments and questions. We will gather those. The Indigenous Advisory Committee will be meeting on an ongoing basis. We can bring that to them. And I just want to say thank you so much. And with that, we will formally close, and looking forward to the additional crucial conversations that we need to have. Thank you, everyone.